So this is going to be a little interactive. It's not a spot test. So, if I look at you, you don't have to answer me. You can ignore me politely. But if you have an opinion, though, feel free to share it. I think it'll make the presentation a little more interesting, because when you put a term like gastrectomy up, then everybody's figuring, well, oh, here we go. This is going to get a little complex. But actually, no, it's not going to be complex. This is going to be interesting, because you ever stop to think that where did all this obesity come from? I mean, we were all minding our own business, becoming more civilized. Okay, we don't look like hopscotch and all that, run around the yard like we used to, but we still walk a bit. So surely, when you look at the change in activity, and our diet has adjusted a bit, separate topic, that is not proportional, though, to the explosion. I mean, everybody around you, not audience included, everybody around you just exploded, correct? I mean, how many of you ever had an issue, and this audience looks a little different from my usual audiences. How many of you know somebody then who has been or is struggling with weight and or diabetes? Most of you. And some of you yourself struggle with that. And so you must wonder, where did this come from? Yes, I hear all that talk about diet, and I need to go on my Mediterranean diet, give up red meat, don't drink so much, sleep better, avoid stress, put in 30, 40 minutes of activity a day, burn in the formula of, food in equals burn, and make sure that I have my homeostasis, my body in balance. Yeah, I got that. But despite that, this epidemic is on a roll. So there has to be then some fundamental reasons. And what I really want to leave with you at this stage of the conversation is to remain curious about the reason, because it is not obvious. Obesity, though it seems that you could look at a 600-pounder, and after you get over your disdain or disgust or whichever emotion that sight brings up in you, once you get over that, you're still stuck with a question. How did they get like that? And along the way, they couldn't have done a little something just to tweak that, just to reverse that. So it must mean, and if they are well-meaning for themselves, then you must accept that they must have made some effort. They must have made efforts along the way. And probably they were just overwhelmed. These are not wicked people. These are not suicidal people. These are people who struggle like you and I to deal with the issues on a daily basis, to make the best choices with food, to prepare food as best as they can with what they can afford or have, to eat as properly as they can. They do all these things, but over time, they seem to be losing a battle. And so what I don't want you to leave here today with is a feeling or an impression that obesity is simple, because it is not. And in my own journey dealing with obesity, I went through all of the emotions. I didn't want to operate on fat people. That was not my choice. In fact, my choice was to do slim and sexy, because I was using telescopes and that was fun. And the concept of having to open a fat person up, that part is interesting. Now you got to try to close them and keep them closed. That part is challenging, especially when the wound breaks down and now you have drama, they're not moving. So you see, it's not a natural attraction for anybody in surgery. But the more you get to understand it, that it is complicated, that it is complex, that you can actually make some significant differences, then it moves into becoming what you all may recognize as a ministry. Because once you get to ministry, you move beyond passion now into making a difference that you could actually bring to the lives of somebody a significant change that can make their whole personality 100% different. That's what's exciting about this whole obesity surgery, obesity management journey. And it's not all about surgery. It's multidisciplinary. Surgery is a tool, and we'll speak today about one of those tools. So, with that, one of the things that we've come to appreciate is that obesity, as you get more fat deposited in the tissue below your skin or in organs, obesity, as that increases, so does your risk for type 2 diabetes. They seem to go hand in hand. And in fact, as you put on more weight, if we were to check what we call the glycated hemoglobin, this HbA1c. Now, some of you may be familiar with it. It's a test to determine how well your blood sugar is controlled. What we note is that as your weight increases, so does the derangement or the abnormality or the poor control of this glycated hemoglobin. And so being a pre-diabetic and being overweight or obese tends to go hand in hand. So a personal story, when I got up to my own 32 or 33 BMI, and you'll see that at that stage, I should have been having a discussion with an obesity surgeon. But I was there, and I tested my glycated hemoglobin, and the normal should be 6 or below. Then mine was 7. So I appreciated that as I increased my weight, I too was pushing myself into pre-diabetes. So it no longer became academic. It was quite real. You do that. And as I took off to 20, 25 pounds, not surgically, fortunately, then my glycated hemoglobin came back down. So they tend to go hand in hand. And unfortunately, my story, though, is probably the 15% of persons who are challenged with either overweight or frankly obese. And the statistics should get you. If you appreciate that 2/3 of our adult population are either overweight or obese. That is striking. And as Bahamians, we love to rank single digits, right? So we either got to be first, second, or third, sixth in the world for obesity. We got to be ranking. So some things we could pull back a little on. We could go to double digits and just be pretty comfortable. And that should be a part of our goal, to move ourselves out of that high ranking in diabetes and obesity, single digits, and push ourselves back. So appreciate then that we are very much up there in our ranking. Appreciate that our chronic disease burden is huge. And in the context of the current topic, the national topic, with or without universal health coverage and national health insurance, et cetera, the chronic disease burden, of which obesity and diabetes are significant contributors, is huge. So that should motivate us to really want to do something about it, or the people around us to get them to do something about it. So I do want you to pay particular attention, secondly then, to the fact that this needs to be a message that you continue to promote, if only to have mercy on our overall national expense. Regardless of whatever we employ, it's going to be expensive. So back in 1611, it was Randall Cotgrave who actually coined the term obesity. And at the time, it meant to overeat or devour. And this is what we've come to appreciate obesity to mean. And this is how we connect when we say obese. If you're obese, we feel you eat too much. Obviously, that definition has changed over time. When we talk about the sleeve gastrectomy, just to jump right into what this topic is about, we're talking about one of 5 available procedures, 5 operations. The one group of operations are called the gastric restrictive operations, and they include the lap band. We put a band here, and most of you would probably know, remember, or recall, or would have heard that I introduced the band back in 2008. And that program has gone pretty well. Whether patients had their bands placed locally or had their bands placed abroad, we have a pretty robust lap band population of patients. A band going around the top of the stomach, creating a small pouch up here. The pouch is about 1 ounce, maybe 2 ounces, so that is all that they can tolerate. The second is application, which simply means we leave the stomach as is and we fold it in along this curve twice. So we reduce the capacity of the stomach. And we turn the stomach, if you like, from a flattened volleyball to a banana in a visual sense. The third is this operation, which is the sleeve. And what we basically do is we disconnect this part of the stomach from its blood supply. We run a stapling device along this portion. We use a calibrated tube in here to make sure we have the right capacity, and we take this out as a specimen. So this becomes a somewhat unyielding banana. Unlike the application that can yield, this would not yield. So this is a little more what we call durable, meaning in about 5, 7, or 10 years, if we were to check the capacity, this would pretty much be what it was at surgery. So those are the three that I want you to bear in mind, and we continue to offer those three. How do they work? Other than reducing the capacity, so you don't have the volume, so you feel full. And obviously that achieves the initial endpoint. You want to feel full if you're challenged because you have an issue with portions, size. So now you've got that done. You also want to take hunger away. And there are receptors on top of the stomach that feed back to your brain to tell you that you're hungry, tell you that you're full, based on the fact that there's only a limited capacity. So feeling full and not being hungry then tend to go together, except in this instance where you have either a sleeve or application, you tend to get hungry a little more often because the transit of food through here is relatively quick. So you may get hungry more often, but your capacity is limited. So in a 24-hour period then, you should not be taking the calorie load that you used to prior to. Fine? So we reduce the capacity, we make you feel full, we take hunger away, and then specific to what we're talking about today, when we take this away, this portion of the stomach has a hormone, so-called ghrelin hormone, that promotes hunger. So if we take the load of ghrelin away, then you see that we've removed that stimulus for hunger. So there's a third mechanism in the gastric sleeve. The hormonal one, from the load that we've removed, the reduced capacity, and the removing hunger in a physical sense by a feedback loop. Just three things. Now, we mentioned the three operations which are gastric restrictive. It is important to point out that the other two, we won't spend any time on them, but the bypass and another operation called a duodenal switch. These are more complicated operations that change your anatomy. And what has happened is patients have become a little unwilling to get into some of the complications associated with these procedures. They come with a burden of having to have the supplements, vitamins, minerals, more frequent bowel motions, some other issues. So they do have some complications. And if you go into the literature or the blogs, you'll see patients talking frequently about issues that they have with a bypass. And if they had a choice, they would not have used that as the first option. If they failed their weight loss, then fine. They understand that that's an available option. And this is what is the beauty of the sleeve. It is not as complex, not associated with as many complications, and can be converted if you fail to a bypass. So the patients love it. So when we talk about obesity, we do talk about the BMI. We'll get into that. But understand that, guys, once you get to 40 in a waist circumference, your risk, you're getting into, and this is not present company, but if you get to 40 and above, then you're getting into significant increased risk for coronary artery disease, cardiovascular disease, so-called visceral or mid-body obesity. That is something that, the glorious bare belly is really not a healthy belly, And there is a definite relationship between the amount of visceral or abdominal fat and your increased risk for heart attacks. So that is something that you must take to your, the men in your world or who who is at or beyond the 40 inches. Just let them know that maybe it's a good idea just to work that down a little under 40. So the risk factors are very, very clear. And then cardiovascular and stroke disease. Strokes and cardiovascular disease, those are the 1-2 killers in our population if you look at why people die. So we're right on point with trying to avoid you dying. Some of the reasons for obesity we can just touch on. And it's important to know that there are many factors that are at play when obesity occurs. We talk about genetic factors, but genetics probably contributes maybe 5 to 7%, very small group of individuals who have a genetic reason. We appreciate that there are hormonal factors, and we need to do hormonal screens on patients who present with resistant, almost, obesity. We have to make sure that they're not dealing with either hormonal disorders in the master gland, in the brain, or the thyroid, or the stress hormone, cortisol, or even insulin, which becomes very disordered. We'll talk a little more about that in relationship to diabetes, but we have to pay attention to the hormonal environment as well. So that plays a role. Recently, there's been this whole attention paid to the organisms or the bacteria in the gut playing a role, actually being another organ system and playing a role in our health. And so disturbing the gut microbiota, we say, or the microbiome, the use of antibiotics, and we tend to use them pretty injudiciously. You feel you have a cold, you borrow a pill, 1 or 2 days, you get better. So, that tends to be a culture. But in doing so, you're disturbing the environment of organisms that happen to be protecting you. So now, other than the injudicious use of antibiotics contributing to resistant organisms over time, you're also contributing to changing your internal environment and in some way contributing to obesity. So now there's another reason to not just borrow an amoxicillin or borrow an ampicillin. Think about it a little deeper, because you don't want to be contributing to your own obesity in being a little indiscreet about how you go about getting antibiotics. Certain viral infections as well. This adenovirus 36 infections, it's found that this particular type, there's a significant increase in the antibodies to this virus in obese persons as opposed to normal. And the mediation in this particular instance is through a process in medicine that we call inflammation. So now you have inflammatory factors as well as infective factors which are playing a role. So again, just to create a picture to you that obesity is not as simple. There are multiple factors at play. It's Cutelet back in 1840 who basically came up with this way of measurement. We do your height, we do your weight, but we understand that in so-called muscular people, mesomorphic, where you have an increased muscle mass, your body mass index may not accurately reflect the amount of excess fat you have. We know that women tend to have more fat in proportion, up to 25, maybe 30%, whereas men, you expect them to have, in terms of body fat, maybe 15 to 20%. And so measuring the body fat becomes as important as doing the BMI, which is as important as appreciating the waist-hip circumference ratio. So there's a number of additional things beyond the BMI to bear in mind that we look at when we are not convinced that your BMI is reflective of your obesity. So if you want to determine what's going on with you, you take your current weight, you go to your goal weight, your goal BMI, and the extra is your excess body weight. And one of the things we use is the excess body weight as a marker to determine what it is that you're trying to achieve. So when patients come and we talk about, okay, what is your goal and what is your goal weight, and we end up with a number, oh, doc, I need to lose maybe 100, 150, 200, 250 pounds, you know, another person, another two people they need to get rid of, then that excess weight, that number, success is measured as a percentage of that. So if you lose 100% of your excess body weight, then, you know, all well and good. That is a wonderful achievement. But our expectation is that you would at least get to 50 or 60% lost in your excess body weight as a result of surgery. You may have other means, diet, for example, lifestyle changes, increased physical activity, that we also add to that to help you to move it down a bit. But in scoring the success of surgery, we look at anywhere from 40 to 60% of your excess body weight loss. Okay, not the 100%. But we'll take it. So surgery then, and most of us who are challenged with weight fall into this category right here. And for example, for your normal height, if you weigh maybe 200-ish, between 200 and 250 pounds, if you're somewhere in there and your height is relatively normal, then you're sitting somewhere in this class here. And this is where most people find themselves, and they can solve this problem by changes in diet, lifestyle, activity. There's no need to talk about surgery in that group. But when we talk about obese and overweight, this is why 2/3 of the population, adult population, end up in this category because of class 1. Now, when we talk about surgery, we're talking about class 2 and beyond. Of course, you know, we do it in style in the Bahamas, so most of the patients are in class 3. And of course, we have the 65s and the 70s, and you know, we have numbers to talk about, so we could create a new scale sometimes for classification of obesity. And the scale only goes up to 70, so we just put 70 plus. And the health risks, just to segue into a discussion about diabetes, the typical risks we talk about: heart disease, hypertension, changes in lipid with excess lipids, you know, lipids and triglycerides, the cholesterol, the plaques in your vessels. That is something that you want to know is associated with obesity. And then type 2 diabetes. And in appreciating type 2 diabetes, the things you want to understand is the insulin is a hormone that's responsible for regulating your blood sugar. Basically, when you eat, your nutrients are converted into this one unit, and that unit is then moved into the cells by insulin. Wonderful hormone. But if you have increased insulin resistance, then more insulin is going to be produced. So in an environment of excessive insulin, you also are not able to use the insulin. The insulin sensitivity is reduced. The insulin resistance is increased, sensitivity is reduced, inflammation abounds, and so you're not able to have what we call good glycemic control. Your blood sugar, your glucose is not controlled. And we do a blood test, your insulin is there, it is high, but there's a lot of resistance and changes in the sensitivity to it, so it's not working. Type 2 diabetes. We talked early on about the HbA1c, the glycemic control. And on that point of glycemic control, just to help you with your homework, when you look at foods, understand the glycemic index you may see sometimes on foods. And the glycemic index is important because the higher the index, the poorer the calorie value. So white bread and brown bread, one slice of both is about 60 calories. But brown bread has a lower glycemic index. So it does not stimulate insulin as much as white bread. So now you get an appreciation as to why people say, well, you know, eat the wheat bread, etc. You look at the calorie count and you go, well, it's the same calories, but it's the quality of the calories. So when you look at that nutritional information on foods again. Just another thing to help you penetrate a little deeply into the glycemic index. When it's high, you don't want it. When it's low, you do. So what's the problem with diabetes? Well, anywhere where blood flows, there's a problem. And those of you who know diabetes will be familiar with the fact that yes, whether it's stroke or can't see or kidney disease, heart disease, losing a limb, a toe, anywhere blood flows, diabetes causes a problem. So the American Diabetic Association in 2014 recommended bariatric surgery for class 2, and this is a point we made earlier. But they made that recommendation in concert with medical monitoring and lifestyle changes. So again, it's a tool, it's an assist. It will help you. If you need to lose that 100, 150 pounds, sure. And in fact, most times if you need to lose 30 to 50 pounds, we don't encourage you into surgery. You could really just take your time and do that. If you need to lose more than 70, then we start that conversation about weight loss surgery. So increased risk, obesity increases your type 2 diabetes, and we know the dangers of type 2 diabetes. So some of the data out of the US, and there's about 200,000 bariatric procedures done annually. And the sleeve gastrectomy then is one that has become a little more popular for some of the reasons that I've mentioned already. The complications associated with the need to make some adjustments because of the more complicated procedures. Patients are not willing to just jump into that because it is a permanent change. And as you start to unravel, then you increase your risk, your complications associated with the unraveling surgery. So why not, as a first step, sort of like to put your feet in the water, you know you need surgery, well, take the step that perhaps may work, will work for you, and would not necessitate you getting into something more complicated with more side effects. Sounds to make a lot of sense. And so patients are driving the popularity then of the sleeve gastrectomy as a result. The lap band, its popularity is diminishing, and in fact, in quite a few patients, we end up having to take the band out and convert them to a sleeve at the same operation because either they plateau or they discontinue their weight loss course, so they're failing in their weight loss, or because there's a problem with the band, and the band sometimes runs into trouble, so we can take it out as a result of those two issues and convert, in some instances, right away. Sometimes where there's a real issue with the stomach, we delay it and convert at another time. And you start to see then, and this number would have been back in 2013, and it's fair to say that the sleeve gastrectomy has moved north of 50% as the operation of first choice for the treatment of obesity. And what's significant is in the bypass is more effective for the control of diabetes. That's a very important point. It is more effective than the sleeve to control diabetes. However, given the points that we made earlier, that the sleeve as an introductory operation, it is effective, not as effective as the bypass, but if you're combining the treatment of obesity with trying to control your diabetes as an introductory procedure, then it is a procedure of choice because of its lower complication rate, minimal change in your life, if you like, and the option to convert to or upgrade to a bypass if you fail. This is just a reminder, back in '91, the guidelines were established for the treatment of obesity, and at that time, it was a body mass index, a BMI of 35 and above. If you have some other comorbidities, and comorbidities would be a whole long list of stuff, you know, obstructive sleep apnea, hypertension, diabetes, changes in lipids, the list goes on as to what is associated with obesity. Those are comorbidities. So if you're down to BMI of 35 and you have those conditions, fine, you would qualify. If you had a BMI of 40 and above, you automatically qualify. And within our population, in our context, we have those patients very easily available. So these are some of the more complicated procedures that we mentioned. going from the bypass to this is the biliopancreatic diversion to the duodenal switch, a lap band that we mentioned earlier, still relatively available, not as popular, but available. I should mention as well that there's an intragastric balloon. There's also an ability to, instead of doing the sleeve on the outside, there's an ability to use an endoscope from the inside and create a sleeve of the stomach from the inside, so endoscopic sleeve. So this is a constantly moving and developing technology of multiple approaches to obesity. So be aware that there will continue to be more medications, more improved therapies for the treatment of obesity as our understanding increases. So for today, if this was 2008, this would have been a lecture about the lap band. In 2016, it's a lecture about the sleeve. In 2020, I anticipate it'll be a lecture about something else. So just understand and appreciate that as our understanding changes, so too would our technology and our implementations. So today, it's all about the sleeve. But more importantly, it's all about getting the patients to the best outcome and the best result. So how effective is the sleeve? Well, if you use it early on, and that's very important as well. We mentioned earlier that, yes, the bypass is a more effective tool for diabetes, but how is the sleeve most effective? Early on. So if you're a diabetic, a long-standing 10, 15 years, you've had diabetes and obesity, it's not likely that the sleeve will work for you. But if you are new onset diabetes with your obesity, then you would qualify and you would more likely get the benefit because you're an early onset diabetic. And quite a number of the patients, that's what we're dealing with because either they're pre-diabetic or they have recently become diabetic because of the explosion, if you like, in their weight. So the sleeve has been shown with long-term data. It is durable, and the point about durability is after 10 years, will I still have sustained weight loss? It's not just weight loss. There are many ways to lose weight. And frequently when patients ask me about weight loss and they say, Doc, have you heard about X, Y, or Z? Whether I have or not, I tell them as long as it's safe, it is likely to give you a result of weight loss. If they say it will, approved by whatever body or not, as long as it's safe, it is likely if it's intended to do so. So it's not a question of whether you will lose weight with one of the thousands of ways of doing it or diets out there. The question is whether you will sustain the weight loss. And quite often patients not only don't sustain the weight loss, but rebound to a weight higher than they were before. So that then puts a definite limit on that particular choice. So that is an important thing to bear in mind. The sleeve improves the medical comorbidities. Quite often our patients go off medications, off hypertensives, antihypertensives, off their diabetic medications, and we have some wonderful patients who have good stories about no longer requiring medications for diabetes, medications for hypertension. So you now see that that burden, that taking multiple tablets every day burden is removed by having an intervention like this. Proven. The patient is satisfied, again, not that it is an operation that has no attendant issues or complications, it does, but when you compare it to the others, it is not as. The complications are not as high, but still, it's an operation, so it's a risk. And improve quality of life. So this is American Society of Bariatric Surgeons statement in 2012 about the sleeve. And then this is a group from Quebec basically echoing the point that was made, which is the laparoscopic sleeve gastrectomy should be considered as a treatment for type 2 diabetes before the disease progression. So early detection of diabetes in the environment of obesity, it's the choice. And then this particular trial, the Stampede trial, which is one that's referenced quite often, it shows that better than intensive medical therapy, and that's a very important point. If you just stuck with intensive medical therapy, it would not compare, if you do intensive medical therapy alone, in achieving blood sugar or glycemic control compared with the sleeve or bariatric surgery. Again, it's not as if you would not get results with pills or multiple pills alone, but compared to surgery and pills, you won't get the result that you desire. And in that particular trial, you begin to see that intensive medical therapy alone, in 5 years, when you looked at the HbA1c being less than 6, intensive medical therapy alone is only 5%. Whereas with the sleeve, you're up to 24, and as pointed out, then the bypass, which becomes a default unavailable operation of the sleeve, fails up to 37%. And it's basically the summary again, that better, more durable.
You've been watching Doctors Hospital Distinguished Lecture Series, presented every third Thursday in the month. Thank you for joining us.